our legal med exam. So within 5 minutes, everyone will join.
Okay, so I'll give an allowance of 5 minutes, and then after that, I'll start whether you are just 30 or even less. Okay.
Okay, doctor. Our legal med exam. So
Yeah.
within 5 minutes,
Did,
everyone will join.
did you come from another class? Did you have another class?
Yes, doctor.
Did
We were having legal med exam. Just now we are done with the exam.
okay. So 30. Okay. Hmm.
À,
Good afternoon. So in your chat box is a form. Please fill up. This is for your attendance for today. And please listen to Dr. Calilung for this afternoon. Welcome back from your academic break.
Thank you, Doctora. So has everybody accomplished the attendance sheet form? Please accomplish the form. before we start the lecture. So there are now 188 students in the classroom. So I think we can start. So the topic for this afternoon are your endemic diseases, and we will be discussing filariasis, schistosomiasis, and malaria.
हेलो पता क्या हुआ हेलो हेलो
Okay, have you accomplished the attendance sheet?
वाईफाई चला गया एग्जाम कनेक्ट नहीं हो
Make sure that you have accomplished your attendance sheets.
तुम क्या टाइम 59 पे किया तो तब भी नहीं हो रहा फिर काफी लोगों का नहीं हो रहा था तो मैंने
And kindly mute.
4 मिनट और दी 1 मिनट कॉल आ रहा है रुक करती हूँ
Excuse me.
हेलो
Okay, let's start the lecture. Can everyone see my screen? It says there filariasis. Can everyone see?
Yes, doctor.
Yes, doctor.
Okay, that's good. So we are going to discuss a very interesting disease entity for this afternoon. And we will discuss first and foremost your filariasis. Now, let's take a look at the epidemiology and risk factors for this particular disease. Now, there are three filarial species. Okay, and maybe from your previous readings, okay, you know that the pathology lies in the obstruction that the worms create in the lymphatic system of humans. Okay, the three filarial species are first, Wuchereria bancrofti, which is the most common worldwide, and we have your Bruchia malayi and Bruchia timori, which are common in Asia. Now, in as far as worldwide distribution is concerned, okay, we have this image just to give you an idea, okay, how big the problem is in terms of global affliction. Okay, so down here you see the legend where there are different colors, and the Philippines and India, okay, belong to the yellow color, and with this color it indicates that our countries have for its management, okay, diethyl carbamazine plus albendazole, because we'll be discussing treatments also. And there are also countries here, as indicated by the blue ones, which haven't really started any, okay, any implementation regards to the administration of medicines, drugs and medicines are concerned. So that's just to give you an idea of the global distribution of filariasis. So let's take a look now at the risk factors involved in obtaining this particular disease. So the infection spreads from person to person via mosquito bites. And the adult worm, okay, lives in the human lymph vessels. It also mates there and produces millions of microscopic worms, also known as your microfilaria, which is actually the infective stage of this parasite. Now, the microfilaria circulate in the person's blood. And as a mosquito feeds, okay, it obtains the microfilaria such that when it bites another person, okay, it introduces the microfilaria to another individual, infecting the uninfected person. So thus the cycle, the vicious cycle ensues, and we have the problem of having this filariasis infection. So if you still remember, and maybe you're done with your parasitology, discussing the different filariasis species, you can see here that there is what we call an infective stage, wherein it's indicated here that when the mosquito, okay, bites an infected individual, it obtains, okay, it gets which ones? The microfilaria, which is the infective stage of the parasite. And okay, as the parasite is introduced to the individual, okay, we now have the maturation of the microfilaria. Okay, so you now have a male and a female microfilaria here maturing into its adult forms. Okay, now as the microfilaria matures, okay, the adults produce sheathed microfilaria that migrate into the lymph and blood channels. Now it is in here that we now have your diagnostic stage. Now that adult, okay, moves as it is introduced, or rather it moves to the bloodstream, and another mosquito, okay, takes a blood meal, it now gets the worms within itself, okay, ingesting the microfilaria. And again, the microfilaria develops in the mosquito, such then it matures to your larvae 1, 2, and 3. And this larvae now migrates to the head of the mosquito, okay, and to its proboscis. Proboscis ready again to ingest the parasite into another individual once it takes another blood meal. So I guess this is, I'm sure you have taken this in your parasitology. So this is just a review of the life cycle of your filariasis. So what happens? What is the pathology we are looking at when, okay, when that filaria, when that parasite is introduced into the human body? So what happens is there is an immune response, both your cell-mediated type and your humoral. Now there is dilatation of your lymphatics. With that dilatation, as it becomes chronic, it will cause mechanical damage to the lymphatics, okay? And in doing so, severe inflammation is elicited, and as your cells, okay, gets destroyed, there ensues calcification. Initially, there is formation of your granulomas, and this will now calcify, which will now cause your lymphatic obstruction. So let's take a look at the details of what happens when, okay, this parasite is introduced into the human being. Now, when this mosquito bites another individual, the larval worms pass from the mosquito into the human skin, okay, just as we have mentioned in the previous slide. Now, these travel to the lymph vessels. As we have seen in the life cycle, they grow into adult worms. Now, this process takes place for about 6 months or a little more. But an adult worm lives for about 5 to 7 years. So it stays there for a good 5 to 7 years. Okay, and these adult worms mate and release millions of microfilaria in the blood. Okay, now people with microfilaria in their blood can serve as a source of that infection for others. Now, our vectors in Africa, it is the Anopheles, and in the Americas, it is the Culex. And in the Pacific and Asia, we have your Aedes and your Mansonia. Many mosquito bites over several months to years, and these are needed to get your lymphatic filariasis. So it doesn't happen that a single bite, you can have it, no, but rather there has to be several incidents whereby the parasite is introduced to the body. Now, people living for a long time in a tropical or subtropical area where the disease is common, these are actually the population who are at greatest risk of developing the disease because of the constant bite that happens from the infected mosquito. So what are we looking at when it comes to disease? So a swelling, okay, and decreased function of the lymphatic system, okay, and there's also weakening of the immune system. These people will have more bacterial infections because your immune system is now weakened, okay, and these bacterial infections become manifest in the skin as well as in your lymphatic system. Now there will be hardening and thickening of the skin, which in this particular image, you can now see an enlargement of the affected leg, resulting into a condition we call your elephantiasis. Now, many of these bacterial infections can be prevented with appropriate skin hygiene as well as skin and wound care. But since this occurrence happens mostly in developing countries whereby emphasis on hygiene and wound care is not very much observed, then we cannot expect an excellent performance of these hygienic measures. Okay, now when males are the ones bitten, they can develop hydrocele or swelling of the scrotum due to infection, okay, with one of the parasites that causes your lymphatic filariasis, specifically that of your Wuchereria bancrofti. Okay, here I took this image just to show you, okay, how the scrotum of a male individual can be affected. You see this, this is actually your scrotum here, and you can see that it has enlarged so much so that there is difficulty for this individual to walk because this is a heavy load. Remember that this scrotum has been stretched, okay, such that this, okay, is actually filled with your fluids because of the obstruction created by the worm. Okay, so let's take a look at the disease and a little of its pathogenesis. So the adult parasites and the microfilaria, both residing in your lymphatics. Okay, now your lymphatic endothelial cells are affected. There is stimulation of the cells of the innate and adaptive immune system. Okay, now lymphangitis and lymphatic dilatation results, which will now, okay, in turn, give rise to the inflammatory and immune mediators production. Other factors are also stimulated, such that the parasite is killed, okay, and then with the death of the parasite, severe inflammatory response, okay, ensues, and then there will now be calcification of the dead parasite, obstructing now the passage of your lymph, resulting into your lymphedema, hydrocele, and with its chronicity, your elephantiasis. And as we have seen a while ago, the hydrocele in your the hydrocele or the scrotal elephantiasis. So in terms of diagnosis, we have what we call a standard method for diagnosing active infection. which is the identification of your microfilaria in a blood smear by microscopic examination. Now, the microfilaria causing lymphatic filariasis circulate in the blood at night mostly. Okay, so it is advised that the blood sample is taken during this particular time. There are also serologic techniques that can be performed, and this is actually an alternative to the microscopic detection of your microfilaria. Now, patients with active filarial infection typically have elevated levels of your antifilarial immunoglobulins G in the blood, and this can be detected using your routine assays. Okay, as we have said, okay, that this parasitic infection demonstrates nocturnal periodicity, such that blood collection is advised to be taken at night to coincide with the appearance of your microfilaria. Thickmere is made and stained with GIMSA or your H&E. Now, for increased sensitivity, concentration techniques can also be used. Now, because lymphedema may develop many years after the infection, lab tests are most likely to be negative during the first few sampling. Okay, this is the life cycle of your Ucheriria bancrofti, by the way. Very similar. What is important for you to note here are the infective stages. The infective stage, which is your microfilaria, okay, and your diagnostic stage. Basically, it's the same, actually. Okay. And as we have said, it's just an image to show you how the diagnosis of your filarial infection is done. Now, we are in community medicine, and we have to look at how do we prevent, okay, its occurrence, and if it's already there, how do we control it? Now, the best way to prevent your lymphatic filariasis is, of course, to avoid mosquito bites. And the mosquitoes carrying microscopic worms usually bite between the hours of dusk and dawn. So we have to see to it that, okay, we are protected specifically during these times. Now, for those people who are living in endemic areas at night, okay, they could sleep in an air-conditioned room or sleep under a mosquito net. Okay, and between dusk and dawn, your clothing, make sure that you wear long sleeves and trousers so that the skin is not exposed and made vulnerable for mosquito bites. Mosquito repellents can also be bought and applied on exposed skin. So it's very basic. Your preventive measures are actually very basic. The problem is if people, do they have the resources, for instance, to acquire all of these things? That is one of the problems, actually. We have the ways and means whereby we can advocate these specific methods on how to prevent mosquito bites, thus preventing the infection from the infected mosquito. The problem is, do we have the resources, okay, for instance, to acquire and purchase these items? Now, as we have said, the best way to prevent lymphatic filariasis is to avoid mosquito bites. Now, another approach to prevention is actually to give entire communities medicine that kills the microscopic worms, thus controlling mosquitoes. There is also what we call an annual mass treatment, which reduces the level of microfilaria in the blood, thus diminishing the transmission of infection. Now, this is the basis of the global program to eliminate lymphatic filariasis, or what WHO has been advocating as the GPELF, or your GPELF. Okay, and I will show you a little more of that a discussion on that strategy by the World Health Organization. Now, public health experts consider that lymphatic filariasis is one of the neglected tropical diseases, or your NPD, and this can actually be eliminated globally. And there has been a global campaign to eliminate lymphatic filariasis as a public health problem. So this has been launched, okay, and it's actually underway. And we can actually take a look at how the World Health Organization is making progress in the implementation of your GPELF. Okay, so let's now take a look at the global program to eliminate lymphatic filariasis, or your GPELF, by the World Health Organization. So in 1997, okay, WHO classified lymphatic filariasis along with other 5 infectious diseases as eradicable or potentially eradicable. Okay, in the same year, the World Health Assembly adopted Resolution WHA 50.29, which called on member states to initiate steps to eliminate lymphatic filariasis as a public health problem. In response to this call, WHO launched your GPELF, okay, in 2000. So what are the components of your GPELF? First component is transmission interruption. And the main and the purpose of this is to stop the spread of infection, whereby, okay, what is the uh, mass action here? It's actually your mass drug administration. So I think I have mentioned this in one of the slides that I've shown you. And the second component is your morbidity control to alleviate the suffering of affected populations. So this is morbidity management and debilitation prevention, or your MMDP. So those are the 2 components of your GPELF. So the strategy actually is, in order for us to control our vectors, which are the ones which carry the disease with them, we have your MDA, which is your mass drug administration, okay, and you have uh, your morbidity management, disability uh, program. So in MDA, these are the things that have to be done. First, you have your mapping. You have to map out which are the places that require your MDA. Okay, then you have the administration of your MDA. And of course, you have to evaluate. Post-administration, you have to evaluate how effective was your MDA had been. So you have what we call your post-MDA surveillance. Now, in terms of the second component is concerned, okay, you have to have an analysis of the current situation and then plan based on the findings of your current situation, and then come up with a minimum package of your MMDP care. Okay, so that is as far as the WHO GPELF strategy is concerned. So this is actually being done in many countries already, and in many countries, this has already been successful. So as I have said a while ago, the components are your transmission interruption, where it is necessary to map out districts where lymphatic filariasis is endemic. Okay. Now, there is also a need for your community-wide mass treatment programs implementation to treat entire at-risk populations. We do not only take a look at maybe a family or two. We look at entire communities which are at risk, so that we interrupt the transmission of the disease. Now, programs based on a once yearly administration of single doses of 2 drugs given together. Now, the following recommended drug regimens need to be administered once a year for at least 5 years with a coverage of at least 65% of the total risk population, the total at risk population. So what are these drugs? So we have this. We have diethyl carbamazine citrate, which is your DEC, given at 6 milligrams per kilogram of body weight, okay, plus 400 milligrams of your albendazole. And I think I've shown you this in the map, okay, where our countries, the Philippines and India, are actually taking these medications. Now, another regimen is your 150 micrograms per milligrams rather, of body weight, ivermectin, plus 400 milligrams albendazole in areas that are also endemic for onchocerciasis. Now, maybe you are familiar with the drug ivermectin, which has been the topic for so much discussion and argument, because this drug is being used by many as a preventive medication for COVID-19. That's why the medical community does not agree with its use, because they know for a fact that this medication, this drug, is actually used for the prevention of parasitic infections. Another is the use of albendazole, taken 400 milligrams, preferably twice per year, in areas that are also endemic for Loa specifically. And then the second component, whereby we talk about your MMDP to alleviate suffering, of course. Successful MDA, or your mass drug administration, will prevent new infections and no new cases of clinical disease. Now, to achieve the second aim, which is your MMDP, to alleviate suffering, okay, a core strategy of morbidity management and disability prevention is needed, which is your MMDP. Okay, so in preventing and controlling this disease, our elimination strategy is based on, in summary, annual treatment of whole communities with combinations of drugs that kill the microfilaria, okay, which are specifically your carbamazepine, okay, and albendazole. Now, as a result of generous contributions from these drugs by companies that make them, hundreds of millions of people are being treated each year. So we have donations, okay, from pharmaceutical companies, which actually manufacture these drugs. Now, since these drugs reduce levels of infection with intestinal worms, benefits of treatment extend beyond your lymphatic filariasis. Now, there has been successful campaigns to eliminate lymphatic filariasis in countries like China, and we will take a look at those countries in the next few slides. So, in as far as WHO with GPLF implementation, here are progress reports that have been reported to WHO. China and the Republic of Korea have actually eliminated lymphatic filariasis as a public health problem in year 2000, 2007 for China, and 2008 for Korea. And out of 73 countries listed by WHO as being endemic for lymphatic filariasis, 18 countries have completed interventions and now are actually conducting surveillance to validate their elimination. Remember the second strategy, your MMDA, they are now actually at the validation stages. There's also an additional 22 countries that had delivered your MDA or your mass drug administration in all endemic areas and are also on track to achieve elimination. There are remaining 33 countries who have not been able to achieve 100% geographical coverage. but 10 of these have yet to initiate preventive chemotherapy or submit evidence that MDA is not required. Okay, so those are progress notes in as far as the implementation of GBLF is concerned. So mass treatment is currently ongoing in 45 countries. 10 countries have not started treatment or submitted evidence indicating treatment is not really required in that particular country. So that is that for your filariasis. Okay, so take a breather and breathe for about 2 to 3 minutes before we go on to the next presentation, which will be your schistosomiasis. Before you go for your break, can you see this slide?
Yes, doctor. You can see.
Okay, so take a breather, maybe 5 minutes, go to your bathroom break, or maybe take a gulp of your coffee so that you don't fall asleep. Okay, can we resume now?
Yes, doctor.
Okay, so the next topic we're going to discuss is your schistosomiasis. Now let's take a look at the key facts about this particular disease. So it is an acute and chronic disease caused again by a parasitic worm. And people are infected during one, routine agricultural, could also be domestic, occupational, or even recreational activities, exposing them to infested water. Now, people who are mostly infected here are our farmers. Okay. It can also be our mothers who actually wash uh, clothing at the rivers unknowingly. Those rivers are actually infested. Okay. Or people who swim, okay, in particular areas which unknowingly are actually infected with your schistosomiasis. Now, this can also occur in people, okay, who lack hygienic practices, and for children, okay, who have play habits such as swimming or fishing in infested water, and this actually makes them vulnerable to infection. So those are the populations which are at risk of obtaining this particular disease, parasitic infection. Now, in terms of control, okay, control is focused on reducing disease occurrence through one, periodic large-scale population treatment. So if you will notice, there is a similarity between prevention and control of disease relative to the parasitic infection that we have discussed previously with this particular disease. But this time, okay, the use of praziquantel is done instead of your carbamazine and albendazole. The approach is also comprehensive, including, okay, environmental and sanitation practices such as the use of potable water, adequate sanitation, and snail control specifically, which will result to your uh, transmission reduction because you will be controlling the carrier, which is your snail. Now let's take a look at your epidemiologic data. Estimates show that at least 206.4 million people required preventive treatment of schistosomiasis in the year 2016, out of which more than 89 million people were reported to have been treated. Okay, so out of the 206.4 million, 89 million have been reported to be treated of the disease. Now, preventive chemotherapy for schistosomiasis, where people and communities are targeted for large-scale treatment, is only required in 52 endemic countries, okay, with moderate to high transmission. Now, these have been identified and listed down by the World Health Organization. Now, how do people become infected with schistosomiasis? Now, people become infected when the larval parasitic forms, which are released by your freshwater snails, penetrate the skin during contact with infested water. Thus, now it's easy for you to understand why our farmers, okay, who um, who wade in waters that are infested, okay, easily contact and acquire this disease. And also, if people, as we have said a while ago, who actually wade or stay in these infested waters for a long time, they are their skin are actually penetrated by the infective organism. So how does transmission occur? Now, transmission occurs when people suffering from schistosomiasis contaminate freshwater sources with their excreta containing parasite eggs which hatch in the water. Now, as the individual, as the individual skin is penetrated, now the larvae develops in the body and the adult forms, which is your schistosomes, actually mature there. Now these adult worms live in the blood vessels and the the female adult worms release eggs. Now these eggs are then again passed out in the feces of the worm, okay, now, and urine to continue the parasite's life cycle. Now others become trapped in body tissues, causing immune reactions and progressive damage to organs. Now this is your life cycle of your schistosoma, and you can see here that you have your three types or three species. You have your Schistosoma hematobium, Schistosoma japonicum, and your Schistosoma mansoni. And if you will examine them, they actually demonstrate specific features. Okay, where your mansoni, shows a lateral spine. Your japonicum is circular in shape with no spine, while your Schistosoma hematobium is oval in shape and shows a spine that is located at one of its poles. So this is now your life cycle where you can see the infective stage as your infective stage here. Okay, your infective stage is actually this. Okay, your free swimming Cercariae, which is released by the snail into the water. And your diagnostic stage, okay, where we can actually see your schistosome eggs, okay, is at this particular area. Okay, when the mature parasites now release its eggs, okay, they release these eggs and these eggs now mature into now these eggs, okay, are released by the mature adult worms. Okay, and this actually, these parasitic eggs can be seen when examined under the microscope. Now, these eggs are released either in the feces or in the urine, depending on the species. Now, maybe you can tell us or you can tell me what specific species will be released in the urine. Okay, and what particular species will also be released in the feces? Because this has a bearing on, chronic infections that can be observed later on in the individual. Okay, now under appropriate conditions, the eggs hatch, okay, and they release their miracidia, which swim and penetrate specific snail intermediate hosts. Now, the stages in the snail include 2 generations of sporocysts and the production of your Cercaria. Okay, so you have now your Cercaria, which upon release from the snail becomes your infective Cercaria, which are the ones which swim, okay, and penetrate the skin of the individual. Now, upon penetration of the skin of the human host, we now have your schistosomulae, okay, which shed their forked tails to become your schistosomulae. Now, the schistosomulae migrate into the venous circulation to the lungs, then to the heart, and then develop in the liver, okay, exiting the liver via your portal vein system when mature. Now, the male and female adult worms copulate, okay, and reside in the mesenteric venules, the location of which varies by species. So, we know for a fact that your schistosoma hematobium, okay, resides in the blank, while the other schistosomes reside in the blank. Just a teaser for you. Okay. Now, schistosomiasis is prevalent in the tropical and subtropical areas, specifically poor communities without access to safe drinking water and adequate sanitation. It is estimated that at least 91.4% of those requiring treatment for schistosomiasis actually live in Africa, okay, which we know for a fact, okay, are most countries that are actually underdeveloped, okay, and are suffering from poverty. Now, there are two major forms of schistosomiasis. We have your intestinal and urogenital, and these are caused by 5 main species of your blood fluke. So, I obtained this from one source, okay, and this is the species and geographical distribution, by the way. So as we have said, the two types, which are your intestinal schistosomiasis and your urogenital schistosomiasis. So in as far as your intestinal, okay, is concerned, so we have your Mansoni, we have your Japonicum, we have your Milungi, and other schistosoma. Okay. In terms of geographical distribution, okay, we have your Mansoni, okay, found mostly in Africa, the Middle East, the Caribbean, Brazil, as well as Venezuela and Suriname. And when we talk about your Japonicum, we find them in Asia, where the Philippines is also included. Now, Mekongi, okay, several districts in Cambodia and Laos, as well as the Lao People's Democratic Republic. And in as far as urogenital schistosomiasis, by the way, okay, so I'm now telling you the answer, okay, okay, as demonstrated by an infection of your hematobium, we find them in Africa, the Middle East, as well as the Corsicas in France. Now, schistosomiasis, okay, going into a little more detail of your schistosomiasis and how its epidemiology affects the different populations. It affects poor and rural communities, as we have mentioned, okay, particularly those with agricultural and fishing industries. Now, women doing domestic chores, as I have said, as those who wash, okay, their clothes in infested waters, such as either doing laundry, are very much at risk and can actually develop your female genital schistosomiasis. Again, inadequate hygienic practices and contact with infected water make children especially vulnerable to infection. Now, children, because they don't have swimming pools, okay, just like what developed countries have, so they wade in the waters unknowingly, which are actually infested with your Seccaria, okay, and definitely, of course, can penetrate their skin, rendering them, okay, infected with your schistosomiasis. Okay, now let us look into the factors that can actually contribute to the development and further perpetuation of this infection. Migration, okay, population movements. When there is movement, say for instance, of people coming from the infested areas and carrying with them the infection, they will actually be the ones to introduce the disease to new areas, thus perpetuating the vicious cycle of um, disease of the disease. Now, we also have increasing population size. Now, with the increase in population size, what is done? There is, of course, corresponding need for power and water, which results in the developmental schemes and environmental modifications, which actually facilitate transmission. Okay, so we modify the environment, and in so doing, okay, of course, the purpose is always to do good, but in doing such, okay, there are also the after effects of which are actually, okay, spreading the especially specifically the infective stages which are actually there, residing there. Okay, and as we modify our environment, what happens? We actually, okay, we carry and transfer, okay, the infective stages of your schistosomes. So other factors, now also with the rise in ecotourism and travel off the beaten track, we increase the number of tourists, okay, who are affected with this, because there is this tendency of people coming from the developed countries to go into the rural areas thinking that they're actually there for culture enrichment. They participate with activities of people in the rural areas unknowingly, okay, rendering them vulnerable to one particular infection, which is your schistosomiasis. Now, at times, tourists actually present with severe acute infection and unusual problems, including paralysis, because, okay, they have actually gone, okay, unknowingly to these places which are actually dangerous, but because of inadequate knowledge, okay, and sorry for the term ignorance, they actually render themselves vulnerable and oftentimes acquiring the infection as they go into this what do you call this, rather behaviors which are actually uh, risky for them unknowingly. Now, urogenital schistosomiasis is also considered to be a risk factor for HIV infection, especially in women. So let's take a look at the presenting signs and symptoms. Now let's go first to your intestinal schistosomiasis. Okay, and this is actually caused by the body's reaction to your worms. Now, the worms are foreign bodies, so the body recognizes them and therefore initiates an immune response to these foreign bodies. So, as a result of your intestinal schistosomiasis, your patients can present with abdominal pain. They can also come in complaining of diarrhea. You can also observe blood in the stool. There will also be liver enlargement in advanced cases. And frequently, this is associated with an accumulation of fluid in the peritoneal cavity, okay, resulting into hypertension of your abdominal blood vessels. So you will notice that these are very similar. You can find this in other um, conditions like abdominal pain, very common, but you have to look into the very important thing here that you have to know, especially when examining your patients, is to find out whether the area is actually endemic for this disease. Okay, so you do not give a diagnosis of intestinal schistosomiasis when this particular disease is actually foreign to that area. So you do not say that the person suffering from abdominal pain or diarrhea has intestinal schistosomiasis when never, okay, in that place have you seen such a case. Okay, blood in the stool, you can also, also very common, and blood in the stools can also be found in your amoebiasis, and so with your liver enlargement. Okay, so you have to be very, very careful, okay, in making a diagnosis of your intestinal schistosomiasis. And as I have said, your history is actually very important here. History, eliciting the history of, say, for instance, is your patient or did your patient um, travel into an area endemic for this particular disease? So you have to elicit those kinds of history if you are suspecting your intestinal schistosomiasis, do not just base your diagnosis from the signs and symptoms that you see, because there are many diseases that can actually manifest as this. What is very important here is you have to elicit, you have to elicit in your history some travel, or exposure to your schistosomiasis. Okay. Now, if we are talking about intestinal schistosomiasis with these clinical manifestations as well as this, then you will also expect the finding of an enlarged spleen. Now, when we talk about urogenital schistosomiasis, the classic sign is your hematuria. And in advanced cases, you will now find fibrosis of the bladder and the ureter. Therefore, with this finding, you will now expect damage of the kidney. Bladder cancer is another possible complication in the later stages of your urogenital schistosomiasis, which is caused by your schistosoma hematobium. In women, urogenital schistosomiasis can present as genital lesions. You can also find your vaginal bleeding. You can also find dyspareunia or pain during sexual intercourse, as well as vulvar nodules. Again, as I have said, this may be found in other clinical conditions, and just make sure that you elicit information that will give a logical diagnosis of your schistosomiasis. In men, you have urogenital schistosomiasis presenting as a seminal vesicle pathology as well as your prostate disease. Now, the long-term effects of urogenital schistosomiasis in men and women is infertility. Now, aside from the direct effects on the individual, now this has actually economic and health effects. So it has a domino effect. So this disease is more disabling rather than it kills, unless of course it becomes chronic, such as patients can die of cancer or whichever disease that results after so many years of infection. In children, we expect to see anemia. We also expect to see stunting, and there will be reduced ability to learn, which is of course reversible if treated early on. Now, chronic schistosomiasis may affect people's ability to work, and in some cases, this can actually result in death. Now, in addition, the number of deaths due to schistosomiasis is actually difficult to estimate because of hidden pathologies such as liver and kidney failure, bladder cancer, and ectopic pregnancies due to female genital schistosomiasis. So it's very difficult to say that the mortality is directly caused by schistosomiasis, because there are other diseases, hidden pathologies we call it, such as liver and kidney failure, which may, as cause of death, not necessarily caused by your schistosomiasis, but can be suspected as schistosomiasis. But the implication there is we cannot directly associate deaths coming from these pathologies as the result of your schistosomiasis. That's why we cannot give exact figures as to how much deaths have actually occurred from schistosomiasis. So with this, there is a need for death estimates due to schistosomiasis to be reassessed. But as data that have been reflected. Now, there is a variation from about 24,067 and 200,000, okay, deaths occurring globally per year. And in 2000, WHO estimated the annual death rate, okay, to be 200,000 globally. Now, this should have decreased considerably due to the impact of a scale up in large-scale preventive chemotherapy campaigns over the past decade. Now, in as far as diagnosis is concerned, as we have mentioned, okay, there should be detection of parasitic eggs in stool or the urine, depending on the species. Now, antibodies and or antigens detected in the blood or urine samples are also indications of infections. For urogenital schistosomiasis, we have what we call filtration technique using nylon, paper, or polycarbonate filters, which is the standard diagnostic technique. And in children suspected of schistosoma hematobium, almost always have microscopic blood in their urine, which can be detected by chemical agent strips. Okay, so the eggs of intestinal schistosomiasis can also be detected in fecal specimens through your Cato-Cats technique, whereby methylene blue stained cellophane soaked in glycerin, okay, and placed in your glass slides is performed. Now, for people living in non-endemic or low transmission areas, serologic and immunologic tests are useful in showing exposure to infection, and the need for thorough examination, treatment, and follow-up is mandatory. So let's now take a look at the prevention and control. Okay, we have the lessons and we have the basis of control. Now, in terms of our basis of control, it has to be large scale, okay, whereby treatment of at-risk population groups are done. There should be access to safe water, and we already know the logical reason for this. There should also be improvement in sanitation. There should be advocacy for hygienic practices, okay? And then, of course, there should be snail control, which carries the your Segeria. Now, what have we learned during the implementation of these programs in the prevention and control of schistosomiasis? Now, there has been successful implementation for the past 40 years in countries like Brazil, Mauritius, Cambodia, China, Egypt, Oman, Jordan, Iran, as well as Saudi Arabia. And it has been reported that there has also been transmission interruption in countries like Morocco, Ghana, Sierra Leone, Tanzania, Yemen, the Niger, as well as in Rwanda. Okay. Now, assessment of transmission status is being made in several other countries. Now, if there are countries which have been successful, okay, in the implementation and transmission interruption has been observed in other countries, okay, in other countries, assessment of transmission are being done, okay? And over the past 10 years, there's also a scale up of treatment campaigns in a number of sub-Saharan countries where most of those at risk live. Okay, so again, the basis of control are the following: large-scale treatment, safe water access, sanitation improvement, advocacies and education on hygiene, and of course, your snail control. Now, what are the strategies in prevention and control of schistosomiasis? Now, this is focused on one, okay, your preventive chemotherapy. Okay, so this actually reduces your disease burden by the treatment of your praziquantel, which should be periodic, targeted, large scale in scope, and addressed to your affected populations. Now, this will involve one, regular treatment of all at-risk groups. In a few countries where there is low transmission, the interruption of transmission of the disease should be aimed for. Secondly, the frequency of treatment is determined by one, the prevalence of the infection. Okay, and we take a look at the infection in school-age children. In high transmission areas, okay, treatment may have to be repeated every year for a number of years. And as we do intervention, such as the application of treatment, we also have to monitor and evaluate to determine whether our implementation programs are doing any good, are they not doing any good, identify the gaps or where did we go wrong, address these gaps, and continue on with the implementation of whatever program is being done. So, in prevention and control, of course, we need to have a strategies and objective. We should have objectives, okay, in order for us to successfully implement these strategies. And of course, that objective is to reduce disease morbidity and transmission. Okay, our strategies is to implement your periodic treatment of at-risk populations, but this has major limitations. Okay, and as our 2016 data reflects, 35.6% of people requiring treatment has been reached globally, with a proportion of about 53.7% of school-aged children requiring preventive chemotherapy for schistosomiasis already being treated. And who are our targeted groups? Number one, school-aged children in endemic areas. Pay attention in endemic areas. Secondly, adults considered to be at risk, like those who engage in occupations rendering them at high risk, living in endemic areas, and people, okay, as I've said, with occupations involving contact with infested waters, such as fishermen, farmers, irrigation workers, and women whose domestic tasks bring them in contact with infested water. Okay, and third targeted group, entire, not only groups, entire communities living in highly endemic areas should receive treatment. Praziquantel, we already have mentioned this. Okay, this is the recommended treatment against all forms of schistosomiasis. Why? Because it is effective, it is safe, and it's low cost. Okay, even though reinfection may occur after treatment, the risk of developing severe disease is diminished by the use of praziquantel and even reversed when treatment is initiated and repeated in childhood. Okay, so that is for your praziquantel. So I guess, okay, so this is just, oh, we have discussed this already. Okay, just for you to remember, okay, take a look at this. You have the three species here, which I know at this time you are already very familiar with. Okay, so with that, okay, we're done with your schistosomiasis. And let me see this. Yeah, I actually have here a WHO update. Okay, this is update in terms of implementation of your schistosomiasis control. Okay, which I think I have already summarized. Okay, in the past 40 years, okay, successful implementation. Yeah, we have discussed this. This is actually an update. And the WHO's response, okay. The World Health Organization, okay, continues to work on schistosomiasis as part of its integrated approach in the control of your neglected tropical diseases. Although medically diverse, NTD share features that allow these diseases to persist in conditions of poverty where they cluster and frequently overlap. So you see the problem in when we deal with the neglected tropical diseases, not only the disease itself, but the problems are actually encompassing because we also have to deal with problems of poverty. Okay, so it's not only the disease we're trying to combat here and try to put solutions to, but the problem is more deeply rooted because there is the problem of poverty and living at subhuman conditions actually. Okay, so the World Health Organization is responding vigorously and actively, and it coordinates the strategy of preventive chemotherapy in consultation with collaborating centers and partners coming from academic and research institutions. Research continues. Okay, the private sector, NGOs, international development agencies, as well as other UN organizations. So WHO also develops technical guidelines and tools for use by national control programs. So it never stops, because we cannot stop this, addressing these problems. Aside from the fact that these are global, they are also encompassing. They're encompassing in terms of involving other problems, not only the specific disease. Okay. So working with partners, okay, with the private sector and all of those that I have mentioned previously, okay, WHO has advocated for increased access to praziquantel and resources for implementation. Now, a significant amount of praziquantel to treat more than 100 million of children of school age per year has been pledged by the private sector and developing partners. So that's what they call this. It's heartening to know that WHO is very active in this, and it is also heartwarming to know that uh, there are concerned, okay, organizations that are actually donating a lot so that these problems, these global problems, can also be addressed. Okay, so that's your schistosomiasis plus an update from the World Health Organization. I was not able to show you the WHO update in Filariasis because I do have an update there. Anyway, let's have another 5 minutes break before we finally go to our last lecture, which is your malaria. And you might be really interested here because in here, in my lecture, India is specifically mentioned in this program or in this lecture. So take a break for 5 minutes. You can have a 2 minutes break. You come back at 4:20 or 4:25 would also be fine. So that's a good 7 minutes. Go to the comfort room, take a glass of water. Hello. So now we have reached the last lab, the last topic of the lecture for this afternoon. So let us now take a look at malaria and preventive programs in malaria. So let's take a look at malaria. So what is malaria? Okay. Is it a life-threatening disease? Yes, it is. Okay. And this is a disease transmitted by the bite of an infected female mosquito, specifically your Anopheles mosquito. There are about 3.3 billion people, which is half of the world's population, who are okay, uh, at risk of getting this disease. Now let's take a look at the incidence facts. In terms of your epidemiology, let's take a look at your incidence. There are about 225 million cases of malaria worldwide and approximately 781,000 deaths every year. Okay, specifically due to malaria. A child dies of malaria every 30 seconds. Over 90% of malaria deaths are in Africa. 200,000 newborns die each year as a result of malaria. So these figures are truly alarming. Okay. Now, 3.2 billion people are at risk of malaria in 97 countries. In 2013, about 198 million cases of malaria, 584,000 of them died in 2013. In 2014, okay, 2,042 malaria cases have been reported from Bihar, 619 of which were due to your Plasmodium falciparum. In 2015, in the World Malaria Report, in India, 70% of total incidence in Southeast Asia occurred in India. So it's 70%, okay? Out of the 100% occurring in Southeast Asia, 70% okay, occurred in India. So, who are the people affected? Who are the people affected, do you think? We have pregnant women and children under the age of 5 are most vulnerable to malaria infections. Now, this is because they have lower natural immunity to the disease, okay, compared to others in the community. Do you agree? Yes, of course. Okay, who else? Who else do you think are affected? How about this? How about this this person here? He's an adult. Okay, both of these are adults. They can also be affected by malaria. But, okay, if they have lived in the same area for a long period of time, they are likely to develop some kind of immunity to the parasite. But this does not mean, however, that they are not infected, okay, but may mean they will have less severe symptoms. You agree? Now, people who travel, like this traveler here, who travel, okay, from malaria-free areas to malaria endemic areas are at risk of contracting the disease. Okay, holiday makers, immigrant workers can be vulnerable to the infection as they do not have any immunity to the disease. Okay, drugs are available, okay, that can actually give protection to these individuals if they become infected. So these are the populations who are at risk: mothers or pregnant women, young children, okay, adults living in endemic areas who have developed some kind of immunity to the virus, to the infection, and we have, of course, our travelers coming from countries without the infection. So where is malaria a problem? This map actually shows where Plasmodium falciparum is endemic around the world. And you can see here that the highest levels of malaria are between the tropics of Cancer and Capricorn, which is these areas here. Where the Philippines, our country, as sure as your country is, and of course our South Africa. Okay. So let's take a look at these beautiful images. Okay. Now these images actually come from 4 regions where malaria is found. Okay. This is an image from Cambodia in Southeast Asia. Okay. And then top right, this is actually in Tanzania, quite developed. And then we have a shanty town here in India and a remote rural village in Peru. So if you will notice, it's actually all over the world. Okay, so let's take a look at this further. So why is malaria, do you think, a problem? Now, it is a problem because malaria has a significant economic impact on countries with high levels of transmission. In affected countries, the disease actually accounts for 40% of public health drug expenditure. Can you imagine that? It's 40%. 30 to 50% of inpatient hospital admissions and up to 60% of outpatient health clinic visits. Okay, so it implies that malaria causes significant economic losses, and this actually can decrease our gross domestic product or GDP by as much as 1.3% in countries with high levels of transmission. And it is estimated, okay, that malaria health-related expenditure and lost productivity costs Africa's economy over $8 billion per year. It also deters foreign investments, tourism, and trade. Now, these sustained annual economic losses have resulted in substantial differences in GDP, okay, between countries with and without malaria, particularly in Africa. So those are the economic implications of why malaria is a problem. So what causes malaria? Malaria is caused by a single cell parasite called your Plasmodium. Very powerful single cell, and yet it has all of these impacts, okay? Not only on the individual, economically, on the individual, health-wise, as well as economically. Now, there are 4 types of Plasmodium that infect humans. we have your Plasmodium falciparum, Vivax, Malaria, and your ovale. Okay. Now, this image actually shows a false colored micrograph, okay, showing one of the life stages of the parasite. It's actually shown in blue in here. These blue things, you have a ring stage here. Okay, and we have, yeah, the several stages here. This one is the ring stage inside the human red blood cell because they parasitize, okay, our red blood cells. Now, this is the life cycle of a plasmodium. Actually, you review the life cycle of your malaria because it exhibits an erythrocytic stage as well as an exoerythrocytic stage inside the human body. But that is not for us to discuss anymore. You kindly review that. Okay, now diagnosis is very important. So how do we diagnose malaria? Now, early malaria can be diagnosed by microscopy and your RDTs or your rapid diagnostic tests. In microscopy, it uses a blood smear to identify whether parasites are present or not. Okay, a thin smear may be used, or a thick smear can also be used. Now, your rapid diagnostic tests, excuse me, are quick tests that use a drop of blood from the fingertip to identify whether parasites are present in the patient. Now, early diagnosis and treatment of malaria reduces the disease and prevention of death. It also contributes to reducing malaria transmission. That is why it's essential, okay, that diagnosis is done and early treatment is implemented. Okay, so in here, this slide just shows you that there are two ways of diagnosing malaria. One is microscopy, and the other is the use of your rapid diagnostic tests. How about treatment? As far as treatment is concerned, malaria can be treated with antimalarial drugs, and WHO recommends artemisinin combination therapies, okay, to treat your Plasmodium falciparum. Drugs such as chloroquine and primaquine are recommended for Vivax malaria. Okay, antimalarial drugs actually kill the parasite, but do not prevent the patient from being reinfected. Okay, it treats when you have the disease, but it does not prevent you from being reinfected. Early and effective treatment of malaria with antimalarial drugs can shorten the duration of the infection and prevent further complications, which could be fatal. Okay, so now you see the importance of having the treatment early on. Now, in terms of prevention, okay, here are the key methods to prevent malaria transmission. We have what we call our LLINs, or your long-lasting insecticide impregnated nets, your LLINs. Okay. Now, we also have your insecticide treated nets, or your ITNs. An indoor residual spraying can also be implemented, application of mosquito repellents, as well as preventive drug treatments. Now, protection from mosquito bites and controlling vector populations are effective methods of preventing malaria transmission. Vector control, in particular, works to reduce malaria transmission at a community level and can significantly reduce transmission from very high levels close to zero. For individuals, personal protection such as for personal protection from mosquito bites through the use of bed nets, such as what you can see here, okay, and application of insect repellents is the first line of defense to prevent malaria infection. Now, your ITNs and long-lasting insecticide impregnated nets offer both physical and chemical barriers to your mosquitoes. Now, the WHO Global Malaria Control Strategy, okay, or your WHO GTS for malaria, okay, which is to be implemented, has been started year 2016 to last up to 2030. Okay, now this strategy was adopted by the World Health Assembly as early as May 2015. And the strategy provides comprehensive technical guidance to countries and development partners for the next 15 years. So it's a long-term strategy and treatment implementation. Now, the timeline of 2016 up to 2030 is aligned with the 2030 Agenda for Sustainable Development. Now, under the SDG umbrella, two strategies will guide malaria control and elimination efforts, which are your GTS, or your Global Technical Strategy for Malaria, and the Action and Investment to Defeat Malaria, or you aim, also, okay, to be done from year 2016 up to 2030 for a malaria-free world. Now, this strategy provides a technical framework for all malaria endemic countries working towards malaria control and elimination. Now, it also highlights the urgent need to increase investments across all interventions, including preventive measures such as diagnostic testing, treatment, disease surveillance, as well as in harnessing innovation and expanding research. Now, the vision for a world-free malaria. Let's see where we are, okay? Now, the goals of which are to reduce malaria mortality rates globally compared with 2015. And I have shown you the figures previously relative to 2015 epidemiologic data. Reduce malaria case incidence globally compared with 2015. Eliminate malaria from countries in which malaria was transmitted in 2015, and prevent the establishment of malaria in all countries that are malaria-free. So these are our milestones that at 2020, at least 40, okay, aligning with the goals here. Here are the figures that we aim for. We have aimed for, we are aiming for year 2025 up to the year 2030. So let's take a look at the strategic framework. We have what we call pillars, the 3 pillars with their supporting bases. So pillar 1, to ensure universal access to malaria prevention, diagnosis, and treatment. Pillar 2, accelerate efforts towards elimination and attainment of malaria-free status. And Pillar 3, to transform malaria surveillance into a core intervention with support bases as harnessing innovation and expanding research, and secondly, the strengthening and provision of an enabling environment. So for the strategic framework 1, Pillar 1, which ensures universal access to malaria prevention, diagnosis, and treatment. Okay, the prevention strategies are based on 1, vector control and administration of chemo prevention. Secondly, universal diagnosis and treatment of malaria in public and private health facilities. Pillar 2, accelerating efforts towards elimination and attainment of malaria-free status by the following activities: active case detection and case investigations, okay, use of medicines for prophylaxis or other possible new approaches to remove infectious reservoir, and thirdly, innovative solutions. Excuse me, are you discussing? Are you listening? Hello? Do you know what I'm talking about? That you don't have any need to listen? You might just get 100 in my exam. Pillar 3, in transforming malaria surveillance into a core intervention. Okay. All endemic countries and those susceptible to the reestablishment of malaria should have an effective health management and information system. Okay. The use of your mass media. Identify gaps in national programs where failings have occurred in the implementation of programs. Okay. Detect outbreaks, assess impact interventions in order to guide changes in program orientation, and as our support, group support to these pillars, the first one of which is research, whose aim is to harness innovation, okay, and we do this by increasing engagement in basic, clinical, and implementation research, where basic research is essential for a better understanding of the parasites, vectors, and to develop more effective diagnostics and medicines. And to do this, we also have to improve and innovate vector control methods and other tools, such as the development of vaccines. And our support measure our second is strengthening strengthening the enabling environment, which mandates us to have a strong political commitment, robust financing, and increased multi-sectoral collaboration, plus the use of timely replacement of long-lasting insecticidal nets or application of indoor residual spray. Okay, as I was saying a while ago, okay, I have mentioned that India was a special mention here. And this is actually the national framework for malaria elimination for India, year 2016 up to 2030. Okay, so we have, this is in line actually with the WHO Global Technical Strategy, okay, your GTS 2016-2030, and the Asia Pacific Leaders of Malaria Alliance, or your APLMA, okay, and your malaria elimination roadmap for the Asia Pacific. Now, maybe you will be interested in here. And maybe instead of me discussing this, may I ask any one of you, okay, since you're Indian students, right? So let's take a look at the currents in India. How India is going in terms of your malaria problem. May I ask that somebody who was talking a while ago to share us, what do you know about what's happening in your country relative to malaria? Give us maybe some currents. What's the current status of malaria in your country? What your country is doing about it? Okay, and what is the status of your malaria prevention as of now? I need 3 students to give me answers to this. You have interrupted the lecture, so now I will ask you to continue the lecture. Somebody? How about, let's call on, I heard male voices a while ago. How about Bagirat?
Yes, doctor.
Yes, I'm not saying that it was you who was talking a while ago, but I would like to hear, okay, from you. Maybe you can tell us about if there is an existing program of malaria control in your country.
Yes, doctor. We have the some vaccine.
Yes,
Uh,
you do have a malaria control program in your country.
yes,
Okay,
doctor.
can you tell us something about concrete steps that are being done in terms of malaria prevention? Or maybe you can start with epidemiologic data, like how many, okay, in your country. What are the statistics of malaria in your country? Anybody who can volunteer? Hmm? Yes. How about Chandra Mohan? Yes, it's your country. You should know something about what's happening in your country aside from COVID-19, because malaria is a big problem in India. We still have 15 minutes. I would have been very happy to share this lecture to you because it actually refers specifically to your country. How about Ibrahim Sayed? Maybe you can just take a look of a community in your country, a community that has a that you can just discuss to us maybe about the current incidents, the current statistics of malaria in your country. Maybe you can tell us about prevalence rates. Or maybe you can tell us about the program, what your country is doing about the problem, if there is a problem. Yes? Now, students, let me tell you something. Okay. When professors come in and give you a lecture, we see to it that we prepare for your lecture. So as much as possible, okay, please be polite. Okay, the least that you could do is sit down, focus, concentrate, and do not interrupt the discussion. If you want to discuss, do it after the lecture. I would very much appreciate that. Okay. I do not want being interrupted during my lecture because it distracts, okay, the flow of thought. And I don't want that. Okay. Now, this does not mean that since I have not discussed this particular program specifically for India, it does not mean, okay, that this will not be part of the MCQs in your exam. What I'm going to do here is make this as a take-home assignment for you, okay? Anyway, it's here. Okay, malaria elimination in India. You have the national framework here for malaria. Okay, research on this. It's your country anyway, so you should be interested in it. What's in there? Okay, know this individually. I'm not telling you to group yourselves and research on this. No, you have to know this individually. Okay, and this will be a part of the MCQs that I will be giving in the exam. Okay, so it's now 10 minutes to 5. So you might be very tired, okay, since you came from another lecture before this time. Okay, and since you have interrupted the lecture and we have also lost, the flow of thought has been interrupted and I don't feel like giving this lecture anymore. It's because I know that you are knowledgeable about this because, well, anyway, it's really coming from your country anyway. So I will call it a day with a specific assignment for you, okay, to research on this so that you will at least know the answers for the questions I will be asking in the exam. Okay, is that fair enough for you? Yes, I think that's fair. So, Dr. Andres, are you still around? Doktora?
Thank you.
Ay, Doktora.
Yes.
Oo, in-assignment ko na lang to.
Alright.
Nagsasalita eh.
Oo nga eh.
Ay, hindi kaya I'll just give that as an assignment to them.
Okay.
Specifically, India ito eh. I really took this because it's a country, so I got it. Pero hindi naman sila interested, so I'll give it as an assignment. Okay lang ba yun, Doktora?
Your professors are exerting effort so that it will be relevant to you. So, please listen and show appreciation. I know that it's hard because of what is happening in India. You may not be 100% with us, but please do try. You have to be doctors because your country will need you in a short while. All right. So let's next week will be an exam for the ones that we were not able to give exam on. So long 1 and 2 will be combined. So I purposely did not give exams because I knew that most subjects would be giving their exams this week upon resumption. So we will have it next week. So study the topics before long exam 2. So this topic I think not included yet. All right. So see you Tuesday for your long exam 1. Okay. Thank you,
Okay.
ma'am.
Okay, thank you. Thank you, Doctor, and thank you, class, for attending.